Hi everyone, and welcome to this month's Force Society for Kids Mental Health monthly information and networking session. This month's topic is post-traumatic stress disorder, and Dr. Nancy Prober will be our expert, and I will introduce her in a moment. My name is Julie Collette, and I'm the Force Society Parent in Residence at the Kelty Mental Health Resource Centre here at BC Children's Hospital. All In the Know sessions have been recorded, and you can watch them at any time after this presentation. When you go to the Force Society website, the In the Know section, look for the word archives. So as I said, in a moment, I will introduce Dr. Nancy Prober. First, I'd like to please remind everybody to make sure to fill in the feedback forms. They are in the presentation links at the bottom right of your screen. There is a little chain link icon. Please go to that, and there are additional resources as well as the feedback form. This feedback form is very important to us for future planning, and you also have a chance to win a $50 gift card from Chapters. All right. Dr. Nancy Prober is a clinical doctorate, has her clinical doctorate in psychology from the Illinois School of Professional Psychology. She's a registered psychologist in British Columbia with over 8 years of experience assessing and treating veterans, military, and RCMP members with trauma-related disorders like post-traumatic stress disorder. She was the clinical coordinator for 2 operational stress injury clinics in Winnipeg and Vancouver, where she did clinical work, supervised psychology interns, developed and presented talks on trauma, provided consultation on trauma-related disorders, and participated in program development for the Canada-wide network of Veteran Affairs Canada OSI clinics. Currently, Dr. Prober works at St. Paul's Hospital in Vancouver in Mental Health Wellness Clinic and has a private practice at Changeways Clinic. In her practice, Dr. Prober specializes in cognitive behavioral treatment of anxiety and depression with a special interest in treating post-traumatic stress disorder. She is certified as a supervisor in prolonged exposure therapy by the Center for the Treatment and Study of Anxiety at the University of Pennsylvania. She also serves on the board of Anxiety BC. Gosh, that's a lot of work and a lot of expertise. So welcome and thank you.
Thanks, Julie. Okay, so before I launch into my talk, I thought I could just give a brief overview of what I intend to talk about today. So first of all, I want to cover what is trauma. I think the word gets used a lot in our society, and there's a lot of confusion over, I guess, what we mean by trauma in the mental health field. What are the typical reactions to traumatic events? Most people who are exposed to trauma are going to react in a typical way. Then I want to talk about what is post-traumatic stress disorder. And then from that, from an understanding of what PTSD is and what we think maintains it, what then does evidence-based treatment look like? I'm going to spend some time just describing how children tend to react to traumatic events, and then give some pointers on what parents can do to help them. And then I've got a list of additional resources, and I think the folks that put this talk together have a bunch of resources for you as well. Okay, so what is trauma? Now, when mental health professionals are talking about trauma, they're talking about a very specific thing, and that is an event that's experienced as life-threatening. So usually when this happens, so say a person's in a motor vehicle accident and they think they're going to die, the body reacts in a certain way, and they usually feel fear, helplessness, or horror. In probably the last 10 years, 10, 20 years, there's been some research to suggest that people don't necessarily need to feel this, and in particular, soldiers who are overtrained to respond in very dangerous situations, they report they don't feel fear or helplessness when they're in a life-threatening situation, but later on may still develop PTSD. So it's not doesn't necessarily need to be there. However, if the body experiences a sense of life threat, then they're more likely to develop symptoms post-trauma. So some examples of what we're talking about when we talk about trauma can be things like natural disasters, floods, tsunamis, hurricanes. Motor vehicle accidents are probably, if not the number one, very, very close to the top cause of PTSD in our society. Life-threatening illness or injury, fire or explosions, assault, and this can include sexual assault, physical assault, physical, sexual, and emotional abuse, both as children and also as adults. Often the sudden death of a loved one can create these kinds of symptoms. And then, of course, war or terrorist attack, or I would, some of the attacks that are going on in the schools in the States, I would probably lump it in with that as well. So these are some examples of what we're referring to when we say trauma. It's not an over-inclusive list, but it gives you an idea what we're talking about. So what happens when people are exposed to traumatic events? It's a natural response to danger. All animals have this kind of, inbred response. It's a very primitive response. And I don't know if you've ever noticed a rabbit in the yard. And when the rabbit notices you, what does the rabbit do? I mean, generally, it's either going to scamper away really fast, or it might freeze, maybe hoping that you don't see it. If it's a really aggressive rabbit, maybe it'll attack, but that's unlikely. But other animals may get ready to fight. We have the exact same kind of response, and this is the body's way of mobilizing itself in order to protect itself from danger. If there is a growling dog that's coming towards you, you want your body to get ready to fight or to get out of the way. In some instances, freezing also helps the animal maybe not see you, which could also protect you. And maybe I'll go back just one more point on this slide. This fight, flight, or freeze response is really biologically driven, and it has a lot, I don't know if you've heard of having an adrenaline rush. Sometimes people talk about that. And really that's what's happening when we're exposed to danger, when the body feels that its life is in danger, is there's this adrenaline rush. And all of these physiological changes occur in order for the person to protect itself. So there's increase in heart rate, increase in breathing rate. All the blood kind of flows away from the internal organs. It goes to the muscles to get the muscles ready to work. Often there's a sense, people will report kind of tunnel vision, which could be really useful if you want to make sure that you're looking at danger and not getting distracted by, oh, what a pretty butterfly over there. You want to make sure that your eye is on the rabid dog in front of you. All of the chemical changes that happen help the body to mobilize, to protect itself. So what are typical reactions when people are exposed to life threat? And this, most people who are in life-threatening situations in the days to weeks following those situations are going to have a very typical set of responses that have to do with that adrenaline rush. There can, however, also be a range of responses, kind of depending on the type of trauma, the proximity to the traumatic event, how safe the person feels after the event, the kind of vulnerabilities that person brought to the event. But basically that can range from, feeling really stressed out and having kind of transitory problems, all the way to having more clinical mental health issues like depression, anxiety, or post-traumatic stress disorder. And interestingly enough, I mean, we talk a lot about PTSD in the trauma literature, but depression is actually a far more common reaction to being exposed to life threat. So basically, trauma can impact, because of that biological, adrenaline rush, it can impact our physiology, our thoughts, our behavior, and our emotions. So I thought I would just go through a bit of a laundry list of the kinds of reactions that are fairly typical in the immediate aftermath of traumatic exposure. On the physical end, it's very common that people will be tired, that they'll be jumpy. I mean, if they've still got adrenaline kind of coursing through them, that they may have aches and pains, stomach upset, and often, if the blood is rushed away from our internal organs and not working on digestion because it's more important to work on getting out of the way of danger, it's going to be harder to digest. Muscle tension, fluctuations in eating and sleeping are very common. On the more serious end, we see very exaggerated startle reactions. So if a car backfires, the person will feel like they're jumping to the ceiling, whereas everybody just looks calmer. Visibly shaking and trembling, being spaced out, and then having lasting sleep problems would be on the more serious end. In terms of thinking or cognition, very commonly we see poor concentration. And again, I think this goes along with that adrenaline rush. Forgetfulness, and people will tell me that they're having a hard time remembering. I think that is not so much about memory as it is about poor concentration. If you can't pay attention, it's hard to remember. Nightmares are probably one of the most common reaction in the immediate aftermath of life threat, and that's probably the mind's attempt to integrate what's happened. Thinking a lot about the same thing, so kind of thinking about what's happened over and over and over again, and then having repeated and vivid memories of what happened. And again, the nightmares, the thinking a lot about it, the repeated memories, that's the mind's attempt to understand and process and incorporate this difficult event. On the more serious end, we might see things like having a loss of motivation, so being unable to get going during the day. On the opposite end, some people may react more with anger, maybe anger towards chain of command or people that they thought should have known better and see as in charge and let them down for what happened. So there could be a disregard for rules. There may be thoughts of harming themselves or others if they feel like their emotions are really hard to manage. They may have very violent nightmares, and they may be so totally preoccupied by what has happened that they can't focus on anything else for brief periods of time. On the emotional end, very commonly, and again, this has to do with that fight or flight adrenaline rush, you see irritability, anger, nervousness, grief if there's been some kind of loss involved with the trauma, whether it's loss of home from a fire or loss of physical functioning if you've been injured or loss of a loved one. Often people express their distress as tearfulness, and many times people feel this sense of loss of control, and I think this is very common because most of the time what allows us to leave our homes every day is that we feel the world is generally a safe place and we have control over what happens. Things still can happen that are outside of our control, but we don't tend to focus on that until something bad happens, and then it's hard to regain a sense of control again. And then also it's very common to withdraw and to feel down. On the more serious end, we might see kind of intense anger or rage. We could see panic attacks, so having a really hard time just calming down that central nervous system, and kind of seeing danger. I think that's what panic has a lot to do with, seeing danger around you. Being so depressed that you're just flat all the time, so kind of if emotions become too overwhelming, people may just shut down emotionally as a way of coping. You might see immobilizing depression, so having a hard time getting out of bed, and you may see hopelessness about the future. And on the behavioral end, what's very common is we see conflicts with others. And if people are stressed out, it's going to be hard to get along with others. We might see people failing to meet deadlines at work. If their concentration is poor, or if they're preoccupied, that's pretty understandable. It's also very common to see people avoiding things. And in particular, what they tend to avoid are things that remind them of the trauma, or people, places, situations that remind them of the trauma. And that can be a way of trying to manage those kinds of symptoms that are showing up for them. On the more serious end, we might see people turn to substances, alcohol or drug use, in order to manage their very overwhelming emotions. We might see suicidal or homicidal actions. Again, that's very rare, but on the more serious end. We might see impulsive behavior. And again, I think this can be understood as a way to manage very intense emotions. I once had a client that I worked with who had a soldier who had been on multiple tours, and he was telling me a story of how he was kind of thrill-seeking, probably because he always felt like his adrenaline was way up here, and that's where he felt comfortable. And he was impulsively, had one day kind of taken his sports car and driven underneath a semi-trailer impulsively. So people can do kind of extreme things like that as a way to manage extreme feelings. You might see family violence if there's a lot of anger involved. And some people, if they become very afraid and see the world as a very dangerous place, may prefer to stay home and then become housebound. So kind of to sum that up, in general, very commonly in the first few days to weeks after trauma exposure, we see a lot of the things that I've just listed. It tends to be transitory, so if the right circumstances for recovery are in place, and what we think is most helpful is if people have good social support right after the trauma exposure, and if they're able to calm themselves down or feel safe as soon as possible, those seem to predict the best outcomes. So commonly those symptoms will be transitory. And also if they have a chance to talk about what happened. And for a lot of reasons that's sometimes difficult, but if they can do that, these symptoms are transitory. You might see some relationships strain. Again, that tends to be transitory. And you might also see, people have off days, but it kind of comes and goes. On the more serious end, we see lasting changes in thoughts, feelings, behavior, physiology. And in general, post-traumatic stress disorder, it can't be diagnosed unless somebody has had at least 1 month of symptoms. But we often see that this can last months, even years, if people aren't able to get the help they need. You can also see relationship breakdown. If people have a hard time managing their emotions and managing relationships, then that can be a consequence. And then it can also be difficult to meet demands at work and at home if the symptoms are more serious. So I have a short video clip that is on the Anxiety BC website, and just wanted to show you this because it's a really good description of a person's experience of having had trauma exposure. Just for your information, this is an actor. However, what he's describing is, I would say, very realistic to the kinds of things that I see in my practice.
Hey, I'm Aman. So this is my video blog. I've been having a tough time lately and trying to get some help, or help myself, I guess. Things have been pretty bad this year. Last summer, my cousin and I were in a car accident. This lady ran straight through a red light. Thought we were going to die when I saw the car coming towards us. I got pretty banged up and was in the hospital for a while, but now I'm doing okay. I just keep having these, like, really bad dreams about car crashes or being chased. And I wake up all sweaty and my heart is pounding like it's going to jump out of my chest. I haven't driven since the car accident. My friends they make fun of me because I get freaked out if they start driving too fast. I'm starting to make up reasons why I can't go places, and I won't go down the street where we crashed. At school, I just can't seem to pay attention anymore. Sometimes I start thinking of the crash, and it's like I can't get it out of my head. Totally sucks. I thought it'd get better, but it's just getting worse. I went and saw the counselor at school, and she told me about something called post-traumatic stress disorder. I think that's what I have, and I have to figure out how to deal with it.
Okay, so there's Aman's story. I'd just like to talk a little bit about what PTSD is, and then we'll come back to Aman and talk a little bit about his treatment. But basically what PTSD is there needs to be a traumatic event. So somebody has been through something traumatic, and then there are three basic symptom clusters that we see. The first is, we call it re-experiencing, or kind of revisiting, reliving what happened. Then there's a cluster of avoidance or numbing symptoms, which are kind of the opposite of the re-experiencing. And then there's also hyperarousal, which goes along with that adrenaline rush. As I was saying before, the symptoms need to be around for at least 1 month before the diagnosis can be assigned. And also there needs to be significant impairment. I've seen some people in my practice who have been through a car accident maybe 3 months ago. They're having some trouble sleeping. They don't have kind of enough of the symptoms in order to meet full criteria. And also they're not 100% bothered by them, and they're getting back into their life. So they actually wouldn't meet criteria for PTSD. But there's still, some things that are bothering them. So more specifically, what are we saying when we say re-experiencing symptoms? When people have nightmares, when they have intrusive memories during the daytime when they're awake of what happened, having flashbacks, and this is different from intrusive memories. Flashbacks tend to have an element of dissociation that go along with them, so a person, whether it's for a few seconds or longer, will feel like they are actually back in the traumatic event. Upset by reminders of the trauma. So if a car accident happened in a certain place and they drive by that intersection again, they might be really upset. And then we also see, in addition to the emotional upset, we also see physiological changes that might go along with those reminders of the trauma. On the avoidance side, we see avoiding thoughts, feelings, and conversations about what happened, avoiding people, places, and situations that remind them of what happened, having trouble remembering certain parts of the event, though I have to say that with the exception of traumatic events that happen as early children, very few people report this, and in fact they'll say the opposite. I wish I could forget. It tends to be more of a flashbulb memory. Emotional numbness, so kind of shutting down their emotions. Having a loss of interest in things they used to enjoy. And also there tends to be this feeling of disconnection that may develop from others. Either people will say, the people around me, my friends, they didn't go through what I went through, so they don't really get it. And so then they have a hard time connecting with others again. And I think this also comes from if there's a lot of emotional intensity that you're experiencing with those nightmares and re-experiencing symptoms, often the only way to cope with that is to just shut it all down. And if you're emotionally numb, it's again hard to connect with others. And often people develop a sense that their future is limited. And I differentiate this from suicidal thoughts. This is quite different. This is more just the sense that, I really don't think I'm going to live all that much longer. My life's been threatened once. What's to keep it from happening again? And then the third symptom cluster we see is hyperarousal. So these are, again, all of those things that go along with adrenaline rush. Feeling irritable, having a hard time sleeping, having a hard time concentrating, being really watchful for signs of danger. We call it hypervigilance. But just when you're walking down the street, almost like feeling like you've got eyes on the back of your head, just scanning your environment for danger. And then also startling easily. These symptoms, they tend to go together in terms of, I think about hyperarousal and re-experiencing kind of really going together. I mean, the hyperarousal, that adrenaline rush, it's part of that memory. And when you have re-experiencing symptoms going on and the discomfort of the hyperarousal, it just feels so bad. It makes a lot of sense that people will do whatever they can do to avoid feeling that way. And so you get these avoidance symptoms developing too. So that's what we're talking about when we say PTSD, and how does it develop? And I think it really comes down to being exposed to a threatening event, which activates that survival mode, that adrenaline rush, which is a good thing. We want to be able to react to danger to save ourselves. At the same time, because there are all these physiological changes and attentional changes going on in order to save ourselves, it can overload and disrupt our capacity to understand and integrate what's happened. So basically you've got this traumatic event, the fight, flight, or freeze response gets instigated, which is a good thing. It can often, though, lead to disrupted memory processing. And if you put somebody who's recently been exposed to trauma or with PTSD into an MRI and scan their brain and have them think about what happened, the emotion centers of the brain are all lit up, and the kind of the logic centers of the brain, the part of the brain where our long-term memory tends to get stored, tends to be shut down. And if you were to think about your typical memory, say your birthday last year, you could probably describe it. It has a beginning, a middle, and an end. You can tell it in a logical sequence. There's not a lot of intense emotion that goes along with it. It doesn't disrupt your day when you think about it. The trauma memories that are encoded more in the emotion center of the brain tend to be more fragmented, more emotionally laden. And so basically, because those emotion centers are kind of turned on when we're involved in a traumatic incident, that's kind of how the memory gets encoded. So it's hard to incorporate that into our brain. So a typical trauma memory will have elements that were present during the trauma in it. This can include physical, emotional, and behavioral responses that occurred during the trauma. It can include any meanings that we associate with the event. And these can be realistic. They can also be unrealistic. And if you have like want to diagram what a trauma memory look like, say Amon's memory, it might look something like this. There was this uncontrollable thing that happened. I got hit by another car. Say it happened at the intersection of Main and First. There was a red light. The woman went through a red light, and it happened at 4 p.m., and all of that means danger. In addition to what was uncontrollable was this car that hit him, and she was speeding. It was a lady. Maybe the car was blue. And all of this becomes associated with danger. In addition to that, there's Amon, there's me. I was afraid when it happened. I got hurt. I screamed. All those reactions make me feel incompetent. And now, on top of that, I've got PTSD, which also makes me feel incompetent. And all of these things, all you have to do is come into contact with one reminder. It can activate this whole network. So say Amon comes across a blue car. The memory gets evoked. He's reminded of what happened. He feels a sense of danger. His whole hyperarousal system gets going, and he feels incompetent. So an easy solution to that is just, avoid all blue cars. Don't have to feel any of that. And, people tell me avoidance works, and it does work in the short term. In the long term, though, the consequences is that avoiding triggers can then control decision making. As long as I take another route except going, through Main and First, then I'll be okay. Doesn't matter if it takes me 15 minutes out of my way. Life experience starts to narrow if you no longer do certain things to avoid feeling certain ways, which can prevent new learning from taking place. It's hard to learn again that most of the time it's safe to drive if you're not putting yourself in these situations again. And then the trauma memory just remains frozen because there's no new learning. So what's the solution? Basically, it's what we call exposure. And Wikipedia defines that as repeated confrontation with situations and objects that cause distress but aren't inherently dangerous. I'm not going to put a client of mine in a dangerous situation, though they may feel like I am, because they still associate, say, Amon would still associate a blue car or Main and First with danger, when most of the time, most of us would probably agree it's not dangerous. So how does exposure work? One, we're breaking the habit of avoidance. And that helps people to learn that the trauma memories and situations aren't dangerous. So going back to that diagram I showed you, there's that connection between the memory and danger, and we want to start to loosen that association. People then start to learn that their negative feelings eventually dissipate as they continually confront what they believe is dangerous, and nothing happens. And they also learn to discriminate between what happened then and what is happening now. And if you talk to somebody who's having intrusive memories of the event, it feels as if it's still happening. The past feels present. And so by repeatedly putting themselves in situations that are generally safe, that remind them of what happened, they start to learn that what is past is past. And as they do this, they start to gain more of a sense of control and a sense of competence. It's not the memory controlling them and their behavior. They're in control of the memory. So evidence-based treatments tend to include elements of exposure, and also cognitive processing, which I guess is just a fancy way of saying making sense of what happened and being able to put it away. Therapies like this include cognitive processing therapy, EMDR, eye movement desensitization and reprocessing, and also prolonged exposure. Prolonged exposure is a treatment that I have been trained in and tend to focus on. It's a type of CBT treatment. It has a very large body of empirical research that suggests that it does work. There's positive results with a very wide variety of traumatic incidents, from working with war veterans to motor vehicle accidents to people who've been raped. It's a 10 to 15 session protocol, and that doesn't mean that the symptoms are 100% gone or the person's life is 100% on track at the end of 15 sessions, but certainly there is a lot of improvement at the end of 15 sessions. And generally, like any CBT treatment, it includes work in between sessions or homework. So here's another clip of Aman, and he's starting his exposure treatment.
Hey, so I decided to record my steps to get my life back. I was in a really bad car accident last year, and I can't drive anymore. It's like whenever I get in the driver's seat, every part of me screams, "Get out!" The counselor at my school gave me some strategies about how to overcome this fear, how to deal with it. We've talked a lot about the accident. I wrote it down in detail, everything I was thinking and feeling, and it was hard. Like, I usually try not to think about it. But now it doesn't seem so intense. Like, my memories of it don't bother me so much anymore, and I don't have as many nightmares. So that's better. But that's because that's what always would plague me is my nightmares. This video of me is basically trying to conquer my fear, I guess, because I still can't drive. And my mom's gonna come along because it's always easier with someone there. So yeah, I'll give that a shot. Over and out for now. Hey, so sitting in the driver's seat, I expected this to be hard, but not this hard. Okay, so I'm gonna turn the car on now. Man, this is tough. This is messed up. The car's not even moving. I'm telling myself I'm not in any danger. That it's just my anxiety, and it'll go down the longer I sit here. So my plan was to drive around the block. I think I'm just gonna sit here for now. I'll check back later. Well, I did it. Not gonna lie, that was not fun. But after about 20 minutes in the car, it didn't seem so bad. The school counselor was right. My anxiety did go down. Even thinking about it now, doesn't seem so bad. I think it'll be easier tomorrow. Yeah, we'll see how it goes. But that's it for now.
Okay. So just to recap that, so in prolonged exposure, there's really two main components to it. We have people doing real life exposure or approaching the things that they're afraid of. So it can include situations, activities, places, objects perceived as dangerous. It can also include things that trigger their trauma memories. And also we have people doing activities that get them back into their life. If they're not going out of, if they don't have the motivation to leave the house, I have them going for walks. And in the session, we have people revisiting the memory, or we call it imaginal exposure. So we will tape that, and then they take the tape home and they listen to themselves going through the memory in between sessions. We find the faster, or the more people listen to it, the faster it gets processed. So I describe processing the memory as kind of like having this really messy file cabinet, and it has all the elements of the trauma memory in it, but it's hard to make sense of it and it's overwhelming. And what we do through this treatment is we create a nice, orderly, neat set of files that we can, open and close the door and take it out, elements of it, and look at it when we want to, but it doesn't overwhelm us anymore. So remember that unprocessed memory of Aman's car accident? And I don't know if you noticed, but there's some broken lines and some straight lines here, unbroken lines. The unbroken lines represent, I guess, realistic associations. He actually got hit, and that actually was dangerous. However, red lights, even though it feels dangerous, realistically aren't. The same with this set of memory elements, and the same here. Screaming, that's what happened. He screamed. Does that mean incompetence? Well, realistically, no. It's part of the adrenaline rush. And then also PTSD symptoms get associated there, but as I've described, it's very reasonable that it developed. So we go basically from this unprocessed memory to this processed memory. See where all the unrealistic associations went? The elements of the memory still exist. We can't erase memory with treatment, nor would we want to do that. But what we can do is help to sort it through and put things in their place. It was still an uncontrollable event that Aman got hit at this intersection at 4 p.m. at a red light, but those elements no longer mean danger, which means he can go through the intersection at Mean and First, and no longer is his adrenaline rush going to get triggered. So that's PTSD in a nutshell, PTSD treatment in a nutshell. I know we're kind of running out of time, but I did want to go through how children may react and the kinds of things that you might want to look out for. I mean, children are still going through the exact same kind of adrenaline rush that adults are. It's just based on developmental stage. They may understand things or react in certain ways that might be different from adults. So research suggests that traumatic life events are fairly common in children, which also means, most of our kids don't have PTSD, so it means kids are resilient too. There's a wide range of responses from mild to severe, from temporary to chronic. And then, as I said, responses vary with age and developmental stage. So young children may lack an accurate understanding of the relationship between cause and effect. So they may believe, especially really young children, that their thoughts or wishes or fears can cause things to happen, which you can imagine if they've been through something life-threatening or uncontrollable, how that might impact their reaction. They are less able to anticipate danger and know how to keep themselves safe, which speaks, I think, to being able to feel safe again once the danger is over. They may inaccurately blame themselves or their parents. And often there's a misunderstanding of cause and effect. They may experience overwhelming stress if their parent is unable to help them regulate their strong emotions. Parents get traumatized along with their kids, and so it's important for parents to take care of themselves too. And they may not be able to accurately express their emotions or needs, which can lead to relationship issues. So preschool and young school-age children, they may have difficulty describing their distress in words. It's very common that they can temporarily lose previously acquired developmental skills like toilet training or being able to be away from their parents when they're at school. This tends to be very transient. Nightmares, just like in adults, nightmares in children are very common. And because of that, they may fear going to sleep. And it's also very common to see them working out the memory in play. At school age, again, these kids are a bit older, you might see some persistent safety concerns and preoccupation with their own actions during the trauma. And also a constant retelling of the traumatic event, which I think we can encourage because we want people to talk about it. That's what helps to put it in perspective. Though they may not have the ability to regulate their emotions, so they may feel overwhelmed by sadness and fear. Sleep difficulties can develop, and they may have trouble concentrating, just like adults would at work. And if they're having a hard time expressing their emotions, their distress may come out somatically, so you may notice more that they're complaining of stomach aches, headaches. And they may also act out their irritability in an aggressive way. And again, that's not having that inability to speak, to talk about what's on their mind. Adolescents are going through very much the same thing, but they may feel self-conscious about their responses, and as a result, withdraw from others. And since we know social support is really important, so that withdrawal can be a difficulty. They may express fantasies of revenge or retribution. They're trying to do something with their anger. They may develop a radical shift in the way they think about the world, and I think we see this a lot in adults too, just that assumption that things are safe, and that the world is safe, and that people are trustworthy. It can be hard to hold on to. And they may attempt to cope with overwhelming emotions in ways that appear self-destructive, drinking or hurting themselves. This can be a way to manage strong emotions, again, if they're not quite sure how to do that. So what can parents do to help? First of all, it's very important to let your child know that it's normal to feel upset or scared when something bad or scary happens. Encourage your child to express their thoughts and feelings without making any judgments about them, and also in their own time to promote a sense of control. Protect your child from further exposure to traumatic events, and that might include media exposure. Help them to feel safe again. Return to normal routines, waking up at the same time, going to school, seeing friends, eating at a consistent time, and reassure your child that it wasn't their fault and that you're going to keep them safe. Give your child the space to express their emotions. Give them a sense of control by offering reasonable options for daily activities, so let them choose their meals or their clothes. If they start to regress, just remember that this is common. Don't criticize it. It'll probably go away on its own. And then, probably number one is parents need to take care of themselves, because your kids can be distressed by your own distress, and it's important that people move towards feeling safe again. So, young children, I think I've already gone through this. For the sake of time, I think I've already gone through those. And then, so what can you do for yourself? Recognize what's happening, give yourself time to adjust, take care of yourself. And this often goes out the door, but make sure you're eating regularly and exercising and sleeping as much as you can. Spend time with supportive people. Communicate what happened to others. And also do enjoyable things, because you need to have fun in order to start to feel better. When a parent has PTSD, remember that the entire family can be affected. And sometimes the healthy spouse or children may start to do things for the person who has PTSD, and so maybe doing more than they should be. And also, children's needs can be very difficult to meet if the parent is emotionally distant or they have less patience. So when should somebody seek treatment? If they need information, if things are getting difficult to handle, if they're feeling hopeless about their situation, and when things seem more lasting than transitory. I've listed a whole bunch of places where people can go for support and for treatment. I'll let you read through those on your own. They'll have a copy of the slides, right?
Yes.
Okay. And also, here's a bunch of really great resources on the web where you can go for additional information. Okay, so we've got some time for questions.
Okay, well, thank you, Nancy. That's a lot of information. And again, parents will have the opportunity to go back and review this presentation. And also, again, there are additional resources put together by the Force in addition to what Nancy has come up with. So there's lots of further help and questions. You can contact the Force to ask questions and make sure that the Force can help you connect in with the services and supports that you need. And if you're not in an area where the Force is located, then you can call the Force will put you in contact with someone, which would be me or my colleague at the Kelty Centre, and we are provincial, so we can help connect you that way. There are a lot of questions. I think the key point, there's so much information, but the key point is something that the Force always talks about, and it's so important. And again, as you mentioned, it often goes out the window when parents are dealing with their kids with this issue or another family member, is putting your own oxygen mask on first, is how we describe it. Taking care of yourself first, just as you would in an airplane. When the oxygen mask falls down, you need to put that on before you can be of assistance to anybody else, small children or others. So parents, again, I think that's really, really key. So in terms of questions, we have a few minutes, and we have several questions sent in from the community PIRs throughout the province. So, question number 1, can you speak to the relationship between PTSD and, as opposed to one single traumatic event, but the accumulation of many significant experiences that a child might have had, including abandonment, loss, and neglect? How is that different? What does that look like?
It's a very good question. Boy, a brief answer is difficult. I mean, certainly children who experience traumatic events, particularly at the hands of their caretakers when they're growing up, are going to, can develop PTSD. It's certainly the things that, the problems that come from that, problems with trust and relationships and emotion regulation, can make people more vulnerable as adults when life-threatening things happen to them then, because they don't have the resources to cope with life threat. There is a concept of complex PTSD. It's not in the the DSM as a separate diagnosis, but we do talk about it a bit differently, and certainly you see all the elements of PTSD in that, but you do also see a lot of problems with, like extreme problems with trust, and then being able to build relationships and being able to regulate emotions. So probably with early cumulative trauma, you're going to see more of what we call complex PTSD.
And I think that also speaks to, as opposed to parents looking at a diagnosis, looking at the behaviors. So, for example, learning ways of anger management. So looking outside the diagnosis and looking at ways to manage the more severe symptoms. So if it was anger management or resiliency would be another one. To look up those topics and learn about that, perhaps.
Absolutely. Yeah.
So another question. Okay, can PTSD go away on its own once the source of trauma is gone?
Well, I think that has to do with differentiating between PTSD as a diagnosis and trauma. Definitely, once the traumatic event is over, and if people have good social support, they're able to calm themselves down, or seek their own natural coping mechanisms and engage in that, to do all the things that we know help take care of themselves, eat, sleep, get into normal routines and all of that, feel connected with their loved ones. Often the typical responses to trauma do die down on their own. Having a chance to talk about it too, and being able to integrate it, I guess, into their life story. Those symptoms will come down over time on their own. When you're talking about PTSD, and again, that has to do with we think it gets developed by using avoidance as a main coping mechanism. So not being able to think about what happened, not being able to revisit either in reality or in their imagination what happened, tends to keep that memory stuck. And so spontaneous healing from that, I think, is less likely. I also think that treatment is quite straightforward when somebody is ready for it. We're encouraging them to start very gradually approaching it again. But I think that memory does get stuck if it's not, if it's kind of avoided.
Okay, thank you. And I think we have time for one more question. And how does PTSD differ from anxiety? Or is it simply another type of anxiety, such as OCD or generalized anxiety disorder?
It's a good question. I mean, PTSD is classified as an anxiety disorder. And the way that the conceptualization that I went through today is definitely based on anxiety as the source. It's fear of danger. And it's also fairly common for people who've been exposed to life threat to develop other anxiety disorders, like generalized anxiety, starting to worry a lot, or just having a lot of panic attacks. I mean, you see that too, or you see it concurrently with the PTSD. Having said that, there are also elements, emotional elements, I guess, with PTSD that you don't necessarily see with other anxiety disorders, like guilt, shame, anger, that because of the nature of what's triggering that memory, right, may also be there and may require additional therapeutic elements. We may not habituate to it or get used to it the way that we do to anxiety.
Great. Well, thank you for answering those questions. They're not short answers, so that's difficult to do. So thank you very much for presenting today for us, and very knowledgeable. And I would just like to mention that next month is collaborative problem solving, which ties into all sorts of challenges we have as parents. So this is a really key one. And please, again, make sure to fill in the feedback forms and let us know what you think of our presentation and how we can do things better. Thank you.